Continuing with the series of webinars on pediatric COVID infection, today we are going to discuss about prevention of infections in a healthcare settings, including protection of healthcare workers. I am Dr. Rakesh Lodha, Professor of Pediatrics at All India Institute of Medical Sciences, New Delhi, and today I will be discussing the presentation under the following headings: how infections spread, infection prevention and control measures, that is IPC measures, which include standard precautions and expanded precautions, and the recommended IPC practices for COVID-19. For any infection to occur, there are three important conditions. Source, this is the place where the infectious agents thrive or live, and source could be people who can be patients, healthcare workers or visitors, particularly in setting of COVID. The person could be symptomatic or asymptomatic. At the same time, the source can also be environment around an individual, which could be inanimate environment, it could be air, stethoscopes, linen, etc. Then we need a susceptible person. For an infection to occur, germs must enter a susceptible person's body, invade the tissues, multiply, cause damage leading to disease. And susceptible person can be healthy who is not vaccinated or not immune because of any prior exposure in the past. The person with a weakened immune system, such as a patient with HIV or someone on immunosuppressants. And for certain infections, additional routes of entry of germs can also increase susceptibility for an infection like surgery, that is surgical site infections, urinary tract infections with urinary catheters. The transmission has to occur through certain routes. It can occur by contact, sprays, splashes, which occur when droplets from coughing, sneezing or talking within 6 feet land on a mucosal surface. It could also occur by inhalation when the germs are aerosolized in tiny particles. This aerosol generation can occur while coughing, sneezing or talking, or while performing aerosol generating procedures such as nebulization, which we will be discussing later. Sharps injuries with contaminated needles and Sharps instruments can transmit infections like HIV, hepatitis B, etc. Now, moving on, the infection prevention and control measures include standard precautions and various contact based precautions. Standard precautions should be followed while taking care of all patients and include the following: hand hygiene, use of personal protection equipment whenever expecting a possible exposure to infectious material, following respiratory hygiene and cough etiquette principles, ensure appropriate patient placement, properly handle and properly clean and disinfect patient care equipment and instruments or devices, clean and disinfect environment properly, follow safe injection practices, ensure healthcare worker safety including proper handling of needles and other sharps, handle textiles and laundry carefully with minimum agitation. Now, while transmission based precautions include precautions to be taken based on patient's illness and procedures, these could vary from contact precautions, droplet precautions and airborne precautions. Hand hygiene is an important measure for containing COVID-19 infection, and this includes hand wash and hand rub. Hand wash can be done with a non-antimicrobial or antimicrobial soap and should be done when the hands are visibly dirty, contaminated with proteinaceous material, visibly soiled with blood or body fluids. For hand rub, alcohol based hand rub should be used. As per the CDC recommendation, hand rubs containing at least 60% of ethanol or 70% of isopropanol inactivates the SARS-CoV-2 virus and should be used. Hand rub is the preferred mode of hand hygiene and should be performed if the hands are not visibly soiled. One should avoid unnecessary touching of surfaces in close proximity of the patient. Now, this picture shows us the steps to perform hand hygiene as per the WHO guidelines. The WHO recommends hand rub to be done for 20 to 30 seconds and a hand wash for 40 to 60 seconds. However, the CDC guidelines recommends at least 20 seconds for both hand wash and hand rub. One should take a sufficient amount of alcohol based hand rub and then perform the following steps as depicted in these pictures. The steps are similar for hand wash and aim that all sides of both hands are decontaminated. When do we need to perform hand hygiene? Now, WHO's 5 movements of hand hygiene shows us the key movements when a healthcare worker should perform hand hygiene, which are 1 to 5. It should also be performed if hands will be moving from a contaminated body side to a clean body side during patient care. Before putting on PPEs, and after removing the gloves or PPE, one should wash hands with a non-antimicrobial or antimicrobial soap and water if there is contact with spores, because alcohols, chlorhexidine, iodophores and other antiseptic agents have poor activity against spores before eating and after using the restroom. Now, this figure shows us the routes by which the respiratory pathogen can spread. So, when an infected person coughs or sneezes or even talks, droplets form which carry germs to short distances, typically within 6 feet distance. These droplets can land on susceptible person's mucosa, that is eyes, nose or mouth, and cause infection. While the smaller droplets or aerosol less than 5 micrometer can be inhaled by a person near an infected source, that is spread by short range airborne route, or these could be carried away by air currents to long distances, that is beyond 6 feet, and could spread infection. The other route through which the virus can spread is through fomites, which form after droplets and aerosol settle on the surface. So, when a person touches this object or surface contaminated by virus infected person and then touches his own eyes, nose or mouth, she may get exposed to the virus. According to the current evidence, the COVID-19 virus is primarily transmitted between people through respiratory droplets and contact route. Earlier it was said that airborne transmissions of SARS-CoV-2 occurs during aerosol generating procedures such as coughing, talking, but now the evidence suggests that this virus may spread even in absence of aerosol generating procedures, particularly in indoor settings with poor ventilation. Transmission through droplets can be prevented by taking droplet precautions, through airborne route by airborne precautions, and to prevent transmission by fomites one should take contact precautions and perform hand hygiene and avoid touching eye, nose, mouth and face. Now, moving on to the use of personal protective equipment. Personal protective equipment act as a barrier to prevent entry of the virus into the body and include the following: gloves. These should be used when touching blood, body fluids, secretions, excretions, contaminated items, mucous membranes or non-intact skin. So, basically before touching any potentially infectious material. Gowns and coveralls when contact of clothing or exposed skin is anticipated. The PPE for contact precautions protects from fomites and includes gown or coverall and gloves. PPE for droplet precautions protects mucosa, the eye, nose and the mouth from droplets and includes surgical masks and goggles or face shield. Surgical mask covers nose and mouth while goggles and face shield provide eye protection. PPE for airborne infection precautions filters air to be inspired and includes particulate respirators. So, now we know that SARS-CoV-2 can spread through droplets, fomites and aerosols. The following PPE are recommended when taking care of COVID-19 patients. So, we need to use approved N95 or equivalent or a higher level respirator. Face masks can be used if a respirator is not available, but while performing aerosol generating procedures such as nebulization, respirator is a must. Gowns or coveralls with or without apron have to be used. If you look at a gown, it does not cover the head, neck and lower legs, while the coveralls are designed to cover the whole body and sometimes even the feet. Most people would use 2 pairs of gloves. For eye protection, one needs to use goggles and or a face shield. Personal eyeglasses or contact lenses are not considered adequate for eye protection. Head cover and shoe cover should be donned if you are using a gown. Patients with confirmed or possible SARS-CoV-2 infection should wear a face mask or N95 respirator to contain spread of infection. Now, coming to the specific types of PPE for respiratory protection. For this, we have respirators which filter air before it is inhaled, thereby providing respiratory protection. They protect against hazardous airborne particles including dust particles and infectious agents, gases or vapors. These differ from face masks as face masks protect from droplets and not from aerosol. Broadly, there are 3 types of respirators: filtering face piece respirators, that is FFPs, half or full face elastomeric respirators and powered air purifying respirators which are called as PAPRs. Now, looking at each of these, we will start with the filtering face piece respirators, which includes the N95 respirators or equivalent. These are disposable half face piece respirators which filter out particles. Filter series available are N, which are not resistant to oil, R somewhat oil resistant, and P oil proof, and the number indicates the filter efficiency. So, various FFRs available are N95, N99, N100, R95, P95, P99, P100, and we have equivalent series like FFP2 or FFP3. Now, most commonly used is the N95 respirator, which means that it is not resistant to oil, and 95 means that it filters out at least 95% of the airborne particles. FFRs are approved by the CDC's NIOSH. At the same time, there are other certifying agencies in various countries, and like European Union, for India it is FFP series. So, for us it would be FFP2 and FFP3. Now, these must be worn throughout the period of exposure. Now, when we are using the respirators, one must perform a user seal check and should be performed each time a respirator is donned to ensure a proper fit. It can be done with positive or a negative pressure check. To perform a positive pressure check, we need to see the picture. We need to also remember that positive pressure check can't be done in a respirator with an exhalation valve. Now, as shown in this picture, one should place hands over the face piece and then gently exhale into the face piece. It is considered satisfactory if slight positive pressure is built up inside without any outward leakage of air at the seal. Leak is present if any of the following is present: feeling of air movement on the face along the seal of the face piece, fogging of glasses, and no pressure built up inside the respirator. To perform a negative pressure check, as shown in the picture, one would place hands over the face piece and inhale gently. It is considered satisfactory if the face piece collapses on the face and you do not feel any air passing between face and the face piece. Either of positive pressure or negative pressure check can be done. If it is unsatisfactory, one would readjust the nose piece and repeat. Now, the other respirators include elastomeric half piece respirators. These are reusable face piece respirators, while the FFR that we talked about were disposable single use respirators. They contain replaceable cartridges of filters which protect against particles, gases or vapors depending on the type of filter. These covers the nose and the mouth. The elastomeric full face piece respirators are similar, except that they provide a more effective face seal and provide eye protection in addition. Now, coming to the powered air purifying respirators or PAPRs, these are also reusable. They contain replaceable filters or cartridges and protect against particles, gases and vapors depending on type of the filter. In addition, they also provide eye protection. These are battery powered with a blower that pulls air through an attached filter and pumps in purified air into the headpiece. The breathing resistance with these devices is low, and at the same time an additional advantage is that there is no fogging when these devices are used. Now, how to don the PPEs? So, first we need to identify and gather the proper PPE to don. We need to have appropriate gown size, appropriate set of gloves, appropriate mask. We need to perform hand hygiene using a hand sanitizer or a hand rub. Thereafter, we put on the gown or coverall, the respirator which could be a N95 or a equivalent respirator, put on the goggles or the face shield, and it should not interfere with the fit of the respirator when we put on a face shield. The flexible frame of goggles should provide a good seal with the skin of the face, covering the eyes and the surrounding areas and even accommodating for the prescription glasses. Fogging may be common when goggles are used, so one needs to make sure that the respirator is well fitting. Two pairs of gloves are used. One pair is donned to begin with and thereafter another pair would be donned. Combination of PPE will affect the sequence and therefore be practical, and we would refer you to watch the videos that has also been uploaded. Now, steps of doffing are equally important, and these should be done slowly and deliberately in a sequence that prevents self-contamination, as this could be one major source of infection for healthcare workers looking after COVID-19 patients. Always take assistance while doffing. There should be a buddy or there would be somebody who would be supervising the doffing, and it is important to perform hand hygiene after every step. First, inspect the gown or coverall for gross contamination, and if it is there, clean with alcohol swab. Remove the first pair of gloves. Using the gloved hand, grasp the outside edge near the wrist or over the palm and peel away from hand. turning the glove inside out. Thereafter, hold in the opposite gloved hand, slide the ungloved finger under the wrist of the remaining glove and peel off from inside, creating a bag for both the gloves, and then discard in the appropriate bin. For removing face shield or goggles, you need to carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from the head. Do not touch the front of the face shield or the goggles. The coverall and gowns, the outside and the sleeves are likely to be contaminated. One should unfasten the ties, should peel away from the neck and shoulder and turn the contaminated outside surface towards the inside and fold and roll into a bundle and then discard. For removing the respirator, lift the bottom elastic over your head first and lift off the top elastic strap and thereafter discard. Do not touch the front of the respirator or the face mask. If we are using a face mask, carefully untie or unhook from the ears and pull away from the face without touching the front, and make sure that you perform hand hygiene after every step of doffing, and finally need to clean up hands again. A few words about the respiratory hygiene or cough etiquettes. We need to place visual alerts at entrance to outpatient facilities to make sure that anybody who has symptoms of respiratory hygiene and cough etiquette has to be followed. Respiratory hygiene and cough etiquette is recommended for all individuals with signs and symptoms of respiratory infection. One should cover the mouth and nose with a tissue when coughing or sneezing and dispose of the tissue after use. One should perform hand hygiene after contact with respiratory secretions and contaminated objects. Ensure availability of tissues, no touch receptacles like a foot pedal operated one for disposing used tissue, and there should be alcohol based hand rub in the waiting area. Masking and separation of persons with respiratory symptoms should be done during periods of increased respiratory infection activity in the community, as is being done currently for COVID-19. Moving on now to the droplet precautions, we need to take these precautions as well. It is important to ensure patient placement for COVID-19. One should evaluate the need for hospitalization. Home care is preferable if individual situation allows, particularly for mild infections and asymptomatic people. If admitted, a single person room with attached bathroom with the door closed is advisable. Airborne infection isolation rooms are reserved for patients who undergo aerosol generating procedures like nebulizations or those who may need intubation and ventilation. These should be designated healthcare workers to take care of only these patients. One should limit the transport and movement of patients outside the room, and one should communicate before transfer of an individual. One should perform procedures and tests bedside wherever possible. One should use portable X-ray machines rather than shifting patients for these tests. If the patient is being transported, he or she should wear a face mask during the transport. Now, let us talk a little bit about the airborne infection isolation rooms. Now, these are single patient rooms at negative pressure relative to the surrounding areas and with a minimum 6 air changes per hour. It is preferable to have up to 12 air changes per hour, but this may be possible only for newly constructed ones or with renovation. It would be desirable to install multiple exhaust fans if isolation room facility is not available, and this prevents the airborne diseases or the aerosols from escaping from the room and contaminating the environment to infect other people. Air from these rooms should be exhausted directly to outside or filtered through a high efficiency particulate air filter, that is the HEPA filter. The room door should be kept closed except when entering or leaving the room to maintain the negative pressure in these rooms. One should monitor proper negative pressure function in these rooms. Now, another big area to look at is the patient care equipment and devices, as these may be contaminated with the body fluids, fomites or blood, and the policies and procedures for containing, transporting and handling equipment should be established. One should remove the organic material using recommended cleaning agents before high level disinfection or sterilization is done. This will enable effective disinfection and sterilization process. One should wear PPE according to the level of anticipated contamination when handling such a situation. It is equally important to take care of the environment. We should have routine and targeted cleaning of environmental surfaces as indicated by the level of patient contact and degree of soiling. Clean and disinfect surfaces that are likely to be contaminated with pathogens. The common ones include those which are in close proximity to the patient, such as bed rails, over the bed tables. Similarly, frequently touched surfaces such as doorknobs need to be disinfected more frequently. Appropriately registered certified disinfectants that have microbicidal activity against pathogens most likely to contaminate the patient care environment should be used. So, in the setting of COVID, the commonly used agent is a sodium hypochlorite solution in a strength of 1% or ordinary bleach. These effectively kill the SARS-CoV-2 virus. Dedicated medical equipment for suspected or confirmed COVID-19 patients should be considered. Now we move on to the safe injection practices, and here we need to use aseptic techniques to avoid contamination of sterile injection equipment. We should not administer medications from a syringe to multiple patients. Use fluid infusion and administration sets for one patient only. Use single dose vials for parenteral medications whenever possible. If multiple dose vials have to be used, both the needle and syringe used to access the vial must be sterile and should be discarded after every use. Do not keep multi-dose vials in the immediate patient treatment area, and these should be stored in accordance with the manufacturer's recommendations, and discard if the sterility is compromised or is questionable. Do not use bags or bottles of intravenous solutions as a common source of supply for multiple patients. These measures are mainly to avoid cross-contamination and contamination of the environment. Now, let us come to the recommended routine IPC practices during COVID-19 pandemic. These are guidelines recently released by the CDC and the WHO. These practices are applicable to all patients along with the standard precautions, not just those with suspected or confirmed SARS-CoV-2 infection. These include implementing telehealth and nurse directed triage protocols, whether the patient can be managed at home or in person or ED, this has to be decided. Screening and triaging everyone entering a health facility for signs and symptoms of COVID-19, and this should include a temperature check. One should reevaluate admitted patients for signs and symptoms of COVID-19 by daily evaluation for COVID-19 symptoms. One should encourage physical distancing. We need to make sure that at least 6 feet distance is there in between the beds in the waiting areas, and modifying in-person group healthcare activities, example by virtual meets or performing such activities in smaller groups. We need to implement universal source control measures, and this means covering the patient person's mouth and nose to prevent spread of respiratory secretions when they are talking, sneezing or coughing. Using a face mask or a cloth face covering to prevent the spread of infection. Universal means that it is recommended for everyone in a healthcare facility irrespective of symptoms, due to the presence of pre-symptomatic and asymptomatic individuals who could still spread the infection. Now, respirators with exhalation valves are not recommended for source control as the expired air is not filtered, and this could possibly spread the infection. Implementing universal use of personal protective equipment by the healthcare workers. In communities with moderate to substantial community transmission, it is recommended that the healthcare workers also wear eye protection in addition to the respirator or the face mask. One would need to use a N95 or a higher level of respirator for aerosol generating procedures. Surgical procedures posing higher risk of transmission, for example ENT surgery. In situations where there is minimal to no community transmission, universal eye protection and respirator recommendations are optional. Now, consider performing targeted SARS-CoV-2 testing of patients without signs and symptoms of COVID-19, and this may happen before admission, before doing procedures, before diagnostic testing in communities with moderate to sustained SARS-CoV-2 transmission. Consider postponing elective procedures, surgeries and non-urgent outpatient visits. One should create a process to respond to SARS-CoV-2 exposure among healthcare workers and others, which includes notifying the health department about suspected and confirmed cases, investigation and management of exposed healthcare personnel, having a dedicated contact tracing team. Now, moving on, we can look at that beyond the general patient care, we need to look at the IPC practices when caring for a patient with suspected or confirmed SARS-CoV-2 infection. In addition to general patient care, one should establish reporting within and between healthcare facilities and to the public health authorities regarding COVID-19 positive cases. Staff working in hospitals should be aware about patients with suspected or confirmed SARS-CoV-2 infection and facility plans for response. One should wear full PPE, which includes respirator or a face mask, eye protection, gloves, gowns or coveralls. For collection of diagnostic respiratory specimens, PPE with respirator should be used. One needs to manage the visitor access and movement within a facility. Only those essential for patient care should be allowed. Environmental infection control measures should be undertaken like routine cleaning and disinfection procedures, and one needs to look at carefully at the aerosol generating procedures. Now let us look at aerosol generating procedures in a bit of detail. Now procedures that generate aerosol include bronchoscopy, suctioning, endotracheal intubation, CPR, nebulization, non-invasive ventilation, etc. Now all of these should be performed cautiously, and if possible one could avoid them, and if we are performing we need to take the following precautions. One should don full PPE, one should use N95 or a equivalent respirator, limit the number of persons during procedure, should ideally take place in airborne infection isolation rooms that are negative pressure rooms. In case we have to give a aerosol medication, it would be desirable to use a meter dose inhaler with spacer instead of nebulizing wherever feasible. One may place a medical mask on face if a child is receiving oxygen therapy with nasal prongs or high flow nasal cannula to reduce the aerosol spread. Now when performing intubation and ventilation, we need to take the following precautions to limit the aerosol generation. One should avoid bag and mask ventilation, and if one has to do it, one should use a viral filter or a heat and moisture exchanger filter between the mask and the bag. The most skilled member of the team should perform intubation, and a video laryngoscope can help in faster visualization. Rapid sequence intubation should be done. A cuffed endotracheal tube is preferred, and if suction has to be done, a closed suction or an inline suction should be done. If not available, clamp the ET tube rather than bagging during suction. Neuromuscular blocking agents should be used during intubation or suction if the patient conditions allow that. Now to sum up, it is important to follow standard precautions for care of all patients. We need to follow expanded precautions depending on the clinical situation. It is important to triage at entry to the healthcare facility. One needs to don full PPE if caring for a patient with suspected or confirmed COVID-19. Avoid aerosol generating procedures if possible, and this particular slide shows some of the references that would be beneficial for you to refer to. I thank you all.